right? Go ahead, Akanksha.
Awesome. Thanks, Brennan. It's my pleasure to introduce Yue, who I think a lot of us already know from her internship here this summer at Semantic Scholar. Yue is a doctoral candidate at the University of Washington in Seattle, where she's doing her PhD in biomedical and health informatics. She has a really interesting background, having also done medical degrees, including an MBBS and a master's in epidemiology from JHU. And I think this gives her a lot of the tools she needs to bridge the gap between clinical medicine and health informatics research. Today, she'll be talking to us about her doctoral work, which focuses on harnessing the power of AI technologies such as large language models to make health information more accessible, understandable, and actionable for the general public. So, yeah, take it away, Yue.
Yeah, thanks, Kansha, for the intro, and really a pleasure for me to be here. Can you hear me clearly? Okay, sounds good. So I will be sharing my work on developing personalized natural language processing systems to make complex health information more accessible. So a quick note, I maybe not see the people online, so feel free to jump in if you have a question or need clarification. So the inspiration for this work actually came from my colleagues when we had an OP class together. It was the beginning of COVID. They asked me questions about COVID at that time, like, are the vaccines safe, or how the virus evolving? To answer them, I would share relevant papers because I actually don't know exact answer. But they found those papers really tough to digest, and they told me that they were reluctant to read those papers. Even though they were out educated, they still have trouble to understand those health information. The ability to find the process and understand the basic health information needed to make appropriate health decisions is what we call health literacy. You may be wondering, are those really that difficult? So here's the chance for you to prove yourself. Can you quickly understand this sentence? Okay, how about this one? No? Great. Yeah, actually, those core content are the same, but the expression is totally different. The last one is more concise, using technical terms and professional language. This is what we usually see in an abstract. Well, the plain language one, same content, but with more explanations and using simpler terms, make it more understandable. So there is definitely opportunity to make those complex information more understandable and actionable, as long as we can put them in layman's terms. Before diving into the technical details, let's take a step back to give you a sense of why this health literacy is important. So could you easily distinguish between accurate health websites versus problematic ones? Or can you fully grasp every details in your patient consent form or your study participant consent form? Actually, health literacy requires all kinds of abilities like reading, writing, filing complaints in the health systems. Even if you are an expert in other fields, health-related tasks can be still a major struggle. These skills just don't automatically transfer over to health domain. And good health literacy is absolutely critical to make the right health decisions and achieve better treatment results. For example, studies show links between low health literacy and greater emergency room use, higher 30-day readmission rates for hospital, and poor adherence to chronic disease treatment plans, and even higher mortality rates for cardiovascular disease and cancer. So when people don't understand health information, it has real consequences. Well, the specific measurements vary slightly between countries. Low health literacy is widespread. For example, a study in South Africa found that 92% of participants were labeled as having low health literacy. And even in developed countries like the United States and countries in Europe, the low health literacy is also a big issue. Now, you might think health information is readily available. After all, most scientific papers can be freely accessed. But here's the catch. Those papers are full of medical jargon and complex long sentences, and it assumes a certain level of background knowledge to understand those content. For the average person, this makes those information isn't accessible to them. So there is a real urgent need to take the scientific knowledge and deliver that in layman terms. And this need is what ultimately drove my research into generating understandable information. The great thing is recent advances in artificial intelligence, particularly large language models, are unlocking exciting new possibilities for generating easy to understand health info. Tasks that previously required extensive manual effort can now be learned automatically by feeding enough examples. So could we automatically generate plain language health summaries by using large language models? So in this talk, I will describe my work to increase health information accessibility through language models. We'll dive into the progress we've made, including building the dataset to translate scientific language into layman term, identify a unique challenge within this task, background explanation, and developing retrieval augmented methods to address that. A key part of this process has been evaluating existing evaluation methods to see if they effectively measure performance for plain language summarization and considering if there might be better options. And finally, I'll broaden the discussion beyond just health information, exploring how we can personalize information and improve communication across domains. Let's examine our initial approach for automating understandable health summarization. So we started with BART, a state-of-art abstracted transformer model at that time. First, the model was pre-trained on massive textual datasets, scraped from diverse internet sources like books or social media. And the model looks at snippet after snippet, trying to predict the next word. And through repeatedly doing this, the model builds an intuitive sense for how we humans string words together and to convey meanings. Then the model are fine-tuned on label data from specialized tasks. This label data consists of input-output pairs, showing examples of expected input and the desired outputs. By fine-tuning BART on news articles, it got pretty decent at summarizing stuff in general. However, it lacks exposure to medical language patterns. It's just like how a student first learn to talk and take undergrad courses for breath, and then they just need additional medical school for specialized expertise. So we hypothesized that continual pre-training on raw medical text could help adapt BART to medical domain and probably will further improve the performance in plain language generation. And we are the first to do this continual pre-training on BART. However, pre-training alone is not enough. We also need paired data demonstrating complex health information mapped to simpler alternatives. Given substantial paired training data, we can optimize BART to translate technical health information into more accessible content. But where can we source those pairs? It turns out many scientific journals actually require authors to submit both a technical manuscript and a plain language summary. So that provides a natural source for our project. And the quality of those pairs is great since they are written by the same authors and the alignment is strong, much better for training compared to unlabeled data. So in our models, for each pair, the scientific abstract will serve as the input and the plain language summary will be the target we want the model to generate. By manually reviewing biomedical journals, we identified 12 that included both scientific abstracts and the plain language summaries. Through a rigorous data curation, we compiled those into a new corpus called cells. And to our knowledge, cells is now the largest and the most diverse dataset available for biomedical plain language summarization. And here's the statistics of the cells dataset. We have over 60,000 pairs, and We look at average word counts, vocabulary size to evaluate word diversity, and flash King-Cat score for readability. Lower indicate more readable. So as you can see here, like compared to the source, target is shorter, has fewer unique words, and is more readable. But actually, the readability score of both source and target tags are at undergraduate level. Like you can see, like 13 indicates first year and 15 indicates third year. Undergraduate level readability actually is not that easy for general population. And for the experiment, both models were fine-tuned on cells, and the BART PubMed model had additional in-domain pre-training. And we used the Rouge L to measure the word overlap with the target. Higher means more similar. And the Flash King-Cat score to measure readability. Lower is more readable. We can see that the in-domain continual pre-training improves both Rouge score and the readability score, highlighting the value of continual pre-training for plain language generation tasks. And human evaluations also confirmed that the model outputs were appreciated. When we asked the human annotators to evaluate the text in grammar correctness, understandability, meaning preservation, and correctness of the key information using Likert scale, interestingly, they rate the model-generated text as superior in understandability and accuracy of key details compared to the human-written one. So 2 reasons why human raters favor model text. The first one, there is an awareness gap where experts overestimate layman's familiarity with concepts or terminology that seems basic from the expert perspective. And second, the model summaries were more concise versus human attempts to explain a lot of things because they don't have a good sense of what information the general population will need. So this explain all terms may increase the burden of reading. Although we set the maximum length of BART model as the same as human maximum length, the model still tends to generate shorter text. So to briefly recap what our initial attempt, we constructed the largest and most diverse dataset and proposed the continual pre-training. And interesting observations, there is a gap between expert and layman's notions of understandable language. And despite size is relatively small compared to what large language models were trained on, or what language model was trained on, this limited label data still benefits the model. So any questions for this part?
I had a quick question. Yeah.
Sure.
From the cells data set, did you notice any differences in the venues? So you kind of mentioned the Fletch-Kincaid scores across 12 different journals. Were those journals pretty consistent in how they wrote the plain language summaries compared to the original, or did you notice kind of interesting differences between those?
Yeah, that's an interesting fact. Actually, we do have a figure in the paper. So we evaluate the readability score across the venues, and there is a huge variance actually. So for example, for the Cochrane, like the systematic review database, is a database. Yes, for the Cochrane systematic review, the readability score is lower compared to PNAS, which is a more diverse topic. And in my personal opinion, Cochrane has more quality control in their plain language summary compared to other journals.
Cool, awesome, thanks.
Thank you. Okay. So next, I'd like to focus on the unique challenge that I noticed in the plain language summarization explanation. So to further understand how experts translate scientific writing into plain language, we looked closely at the transformations when building the cells dataset. So we are the first to analyze the key changes they make. So first, they define jargon that would trip up lay people. So here they provide definitions for ECG, the medical abbreviation. And second, they explain relevant background of key terms like prevalence, mortality, or risk factors, more information about why this question is important. And third, they remove unnecessary details that professionals might want, but they only confuse the general readers. Things like here, 95 confidence interval. Actually, I'm not sure whether every readers know what it is, what it is. So usually, like when the authors generate the plain language version, they will remove that part. And first, rephrase the long, complex sentences into shorter, bite-sized bits of information using simpler terms. And regarding those key transformations, our models, like the BART PubMed one, can achieve removing unnecessary details. Here, it removes the number of participants here. And it can also achieve jargon explanation. It adds the definition of RCT and do the sentence simplification. But there is always a but. Generating relevant background explanations was still a weak point. These backgrounds are crucial for bridging the reader's knowledge gap and increasing the readability of the text, but those information is not available in the source, as you can see here. So how can the model know this new knowledge of a, like if it has never seen it before? So retrieval augmented model seems like an intuitive solution. We could pull in external knowledge, and retrieval augmented generation is a well-established method in natural language processing, commonly used in reasoning and fact-checking. We hypothesize it could generate explanations here. And for the retrieval augmented generation method, we start with a scientific abstract, and an encoder takes the abstract as the query, and a retrieval module that takes the query and retrieve relevant content from a huge external resource. Then identify the top K most relevant content. Concatenate with the abstract, and then a generator like fine-tuned BART we got from the last section could produce a plain summary now with the supplementary knowledge. This is what we call embedding-based retrieval augmented generation. We also explored definition-based retrieval, so concatenating definitions of key abstract terms as generator input. Here we use string match to identify the key term definition from dictionaries. And to avoid evaluating the entire set of abstracts, which may dilute the effects of improving explanations, I derived a subset from cells focusing on the background sections part only, because in my qualitative analysis, I found that most explanations occurs in the background section. So we first examined retrieval source. So UMLS has dictionaries versus Wikipedia definitions. The UMLS Consumer Health Dictionary provides expert written plain language definitions of health terms. We can see that Wikipedia performed better. This verifies the previously observed unawareness gap where specialized overestimate average health literacy actually. And regarding the retrieval method, definition-based retrieval had higher root scores compared to the embedding ones. And the definition-based approach probably aligns better when experts' tendency to use Wikipedia definitions when they write the plain language explanations. And beyond BART, we also tested popular large language models, the open source Llama and closed source GPT. Neither were fine-tuned but prompt with source text augmented with Wikipedia definitions. And both large language models underperformed compared to the fine-tuned BART. Smaller tuned language models works better for this task. And then compare between open source Llama and the GPT. Open source Llama also achieved lower score compared to the GPT, highlighting the limitations of open source model, smaller model size, less pre-training data, and access to less advanced training resources probably. Now, when we used automated scores, BART with embedding retrieval scored lower than definition-based retrieval. But human evaluations show that embedding-based was actually better at meaning preservation, getting key info correct, and ensuring relevance. There is a mismatch between automated scores and human preferences. So the progress on generating explanations, we constructed the explanation dataset and explored retrieval methods and the sources for augmentation. And we observed that regarding the external source, UMLS has coverage and readability limitations. And also regarding the models, fine-tuning the small language models outperformed general large language models in this task, and open source models underperformed commercial ones. And most importantly, we noticed that there is a mismatch between the automated metrics and the human preferences. Any questions for this part?
I have a quick question.
Sure.
So, when you're comparing the relevance of information from Wikipedia versus UMLS, you found that Wikipedia is better for BART, but does that change if you try it for different models, especially LLMs, which have presumably seen most of Wikipedia already?
Oh, you mean BART or the UMI or here the
Here,
results?
yeah. For Llama 2 and GPT, did you try looking at were other external resources better than Wikipedia?
Oh no. Oh, actually, I said another setting for Llama and GPT-4. So for this one, the input is the text augmented with Wikipedia definitions. I also tried the original source without any augmentation, the original abstract, to ask Llama to summarize it into plain language and add necessary explanations to make it more simpler.
Oh,
So that's
interesting.
another setting. But yeah, I actually have the results for. So here you can see the Llama summary is the input is the original source without any augmentation. The prompt is summarize it into plain language, and the explain one is the no augmentation of the source and to summarize it and add any necessary explains and then explanations, and the wiki one is the results I showed in the figure.
It's interesting
So
that the explain ones are better than the wiki ones.
actually, I think that's one of the limitations of wiki as well, because although like I use the definitions from wiki, like the definition from wiki also has the limitation of the coverage. So
That's
probably, yeah, it's not that good match. And also especially for the medical terms, each term has varied definitions and like in different settings. So for the wiki definition, because we only use like the string match, it's very limited to find the correct and appropriate definitions for the specific one.
Makes sense. This is super interesting. Thank you.
Thank you. Okay, let me go. Yeah, so next part. So in the last part, we already found there is a mismatch between the human preferences and the automated scores. And this mismatch made me consider, are our scores actually measuring what matters for plain language summarization? And advancing evaluation is critical because a meaningful and accurate quality measurement ensures proper system performance and efficacy. It will also attract more research and researchers by enabling reliable assessments and better measurement of qualities like simplicity, accuracy, and coherence drives continual progress. While prior studies relied on readability score or human evaluation, these have clear gaps. Readability scores using word and sentence length do not capture key aspects of quality like coherence or fluency, and human assessment is inconsistent and not scalable. So automated scores are needed as they are fast and accurate. However, those automated scores were not designed specifically for plain language summarization, and no one has validated whether they can effectively measure summary quality for this task. So first, we systematically examined whether existing automated scores align with desired criteria. So here are the 4 desired criteria we proposed based on prior work. First, informativeness, whether the plain language version conveys the key info like research questions, interventions, target populations, main results, and simplification. The text should be easy to understand, easy to digest. And coherence, the text is fluent and in a logical arrangement. And lastly, faithfulness, the plain language version should factually align with the original complex scientific text. So to enable controlled testing, we created an evaluation testbed using synthetic data sets and perturbations, intentionally introducing changes to assess model responses. For instance, replacing sentences with simpler versions for different levels of simplification. And due to the time limits, I'll skip testbed details, but happy to chat during the one-on-one meetings if you are interested. And our experiments reveal that current methods fail to properly evaluate simplicity. So we designed a new score to capture simplicity based on perplexity score, which measures how surprised a language model is by text. A lower perplexity score indicates the language model is better at predicting the next word, while a higher perplexity score indicates that the model is less accurate. We wondered, what if we compare the perplexity score from 2 models, one trained on scientific text representing expert knowledge only, and the other on general text like Wikipedia representing lay knowledge. This lay knowledge model never seen the expert knowledge before. So by seeing which model finds the text more familiar, we can evaluate simplicity shifts. However, a problem here, perplexity scores from different models cannot be directly compared since their different vocabulary size will result in score values on different scales. So we map those raw perplexity scores into relative scores compared based on a reference dataset distribution. Here we use cells, and this accounts for model differences. Now we can check if scientific version or general language models find the text more predictable or familiar. And compared to the previous single model perplexity score, this relative comparison means POM score are more compatible across different datasets because currently we map all the scores into a reference distribution. It can also be tailored to specific domains like law or finance or any other domains. As long as the domain-specific model exists, we can use this POM score to evaluate the simplicity shift. So we tested POM on 4 simplification datasets. As expected, POM scores are positive among all datasets. This shows POM can effectively measure simplicity shifts. And POM also responded well to our simplification perturbation in our testbed. In this figure, higher percentage indicates greater simplicity, the x-axis. So POM score increased proportionally to the introduced simplification, matching expected behavior. And in summary, to improve the evaluation of plain language tasks, creating a meaningful and accurate benchmark to attract more researchers to work on this, we designed an evaluation testbed, examine existing methods on the testbed, and then create a new POM score for simplicity. Any question for this part? Okay. So next, I want to broaden beyond just health information, exploring how we can personalize and improve communication across domains. Let's revisit these transformations we identified earlier. Compared to the scientific version, the plain one adds helpful information explaining unfamiliar terms like jargon. They provide definition. Background, they provide the explanations. So this makes me wondering whether we could potentially apply a similar strategy to help researchers communicate cross domains, for example, computer science researchers to read biomedical literatures. So first, probably we can identify terms likely unfamiliar to an individual researcher based on their background knowledge, and then provide additional information tailored to their needs for those specific unfamiliar terms. So we defined two new tasks here: personal level word familiarity prediction and additional information needs prediction. For both tasks, the model input is the term from the abstract to personalize, along with the publication related to the individual. So the outcome is a binary classification, yes or no, and for the additional information needs informed by a human study and prior work, we predict needs for background, definition, and example. Since no data sets existed, we constructed a new one with 100 abstracts from the most viewed papers. We identified the top 10 key terms in each abstract with GPT, and then ask annotators to provide the familiarity ratings and additional information needs. This is how we get this first jargon personalization dataset. So generally, annotators most often select high familiarity for social sciences and art, while technical sciences receives the lowest familiarity ratings, chemistry. And there is a reverse relationship between the information needs and the familiarity. As you can see, the V shape in this figure, more familiar lies additional information needed. And lastly, no matter how familiar it is, people always want examples to learn more about the concept. So let's examine some examples where entities were labeled differently by the annotators. These are a few examples where only one annotator marked an entity as familiar, while everyone else said it was unfamiliar. I did some research on that one annotator. Turns out they have published a bunch of papers on using computer vision for cancer diagnosis and treatment. So even though all the annotators are in the same domain, their specific backgrounds affect how familiar certain terms are to them. And makes sense that this cancer vision researcher would know some medical imaging terms that the others don't. But next question, how can we effectively model those individual background differences? Actually, to model the personal knowledge, we want to measure the distance between a term from the abstract and an individual's background. So here we use the individual's publication to represent the individual's background. And regarding the models, we first use lasso regression, which handles many features, selecting the most important ones and avoids overfitting via regularization. And then we also examine the GPT-4's ability for this personalized task when prompted with the term and the publications from different granularities. And finally, we included a nearest neighbor classifier, which is commonly used in recommendations. So for this nearest neighbor classifier, there is no training, but just assigning the most similar neighbors ratings to the current individual. And the task is a binary classification task. So our results show that Oracle settings, like the nearest neighbor settings, outperforms all other methods, pointing to the benefit of using ratings from similar annotators for predicting term familiarity. But for predicting the additional information needs, as you can see, the incorporating individual features in Lasso helps in prediction, but doesn't substantially improve performance over the nearest neighbor sightings. So here we use F1 score to evaluate the performance. As you can see, like F1 score are not that good, like 50, half. So accurately predicting granular user needs remain challenging without more tailored data and modeling. So this task of personalized jargon identification could help with several downstream applications. For example, by focusing on the most important unfamiliar words, the reading system or writing aid would avoid overloading the user with information. And a recommendation system can also recommend papers that match readers' expertise level, ensuring that reader is not bogged down by unfamiliar terminology. And this personalized jargon identification could revolutionize how researchers find and engage with academia papers, making the entire process more efficient. Although like this, as you can see, there is no clear best approach for this personalized scientific jargon identification. Our dataset and methods present an exciting first step in facilitating researchers to communicate beyond their field. And we also released the procedures and questionnaires used in our data collection. We try to inspire future personalized jargon detection research to aid scientists across other domains. So in summary, to make health information more accessible, we have automated summarization through several advances. First, to construct the largest and most diverse document-level dataset, and then proposing augmented methods to generate explanations, improving evaluation by designing a testbed and new score, and lastly, exploring how we can personalize the information and communicate across domains. So thanks to my training in medical and informatics, I'm good at noticing real-life healthcare issues and figuring out smart ways to fix them. So during my PhD, I expanded my research from solving problems faced by healthcare providers to also helping patients, caregivers, and researchers. And moving forward, I'm excited to continue developing next generation AI for health communication in 3 directions. First, expand improving health information accessibility to underserved populations. And second, continue my work fostering interdisciplinary innovations through literature-based discovery. And last, building on my collaborations with clinicians to advance clinical decision-making with AI. Despite progress, further efforts are important to deploy and evaluate those informations, those health information accessibility improvement system among underserved groups. Currently, plain language text is written by experts, by clinical experts, and assigned by a biased subpopulation. For example, in my own research, the human annotators are UW undergraduate and graduate students. So that's a really biased population to evaluate this like health information accessibility system. So I aim to expand involvement in system design and testing, such as the aging populations whose needs, preferences, and the study participation differ greatly from existing samples. By collaborating and recruiting participants from the underserved populations, this work could better adapt to serve those communities. And secondly, it's incredibly hard to deeply learn a new field when crossing disciplines. So it takes substantial time for innovations to propagate across domains, significantly limiting process. But new possibilities are emerging, like we can use large language models for summarization, paper recommendation, and hypothesis generation. Building on my work modeling researchers' background, I aim to first identify potential collaborations by representing researchers' expertise, and also incorporate knowledge graphs, citations, and large language model to connect work across domains and propose novel hypotheses. And lastly, models that synthesize diverse data can improve patient outcomes. GPT-4 is already embedded within EPIC, which is a hospitalization system. So while generating treatment suggestions with large language model is currently premature, I envision progress made by encoding more inputs. For example, patient-doctor conversations to learn patients' concerns or preferences, and then we can include the information from search engine to learn the most updated public health warnings, and to learn the medical literatures to know the medical evidence to support the decisions. And lastly, even we can have the home assistant dialogue to learn the patient's medication, diet, or sleeping tracking records, etc. We can put them all into the multimodal models. And continue my personalization work, I also see that in-context learning would provide opportunities to adapt the systems to unique clinical settings. We could build single models per patient, like a GPT window for patient. It has access to their full health history, and then this window can be tailored to the hospital or specialty workflows as well to make the decision-making model adapted to the patient, to the specialty, and to the hospital. Large language models also have potential to explain reasoning behind the diagnosis or therapies by logically working through the evidence or the guidelines, highlighting which patient attributes most informed assessments, and refining over time by flagging new data that challenges assumptions or warrants adjustments. Such transparency can increase provider and patient trust. And ultimately, this can enable comprehensive yet personalized models to facilitate accurate clinical decision-making. And I aim to advance this through my expertise area in Alzheimer's disease, cancer, and radiation oncology. So, as a researcher trained in both medical and informatics, I'm dedicated to creating artificial intelligence that can benefit all of the humanity. I see every day how fast the technology is advancing and evolving. I have also seen how much potential it has to improve our lives, especially those are underserved, marginalized, or vulnerable. I have also learned how much responsibilities we have as developers and users of AI technology to ensure it aligns with our values, goals, and ethics. So I think we must be mindful of both the opportunities and the challenges that AI presents to our space and work together to shape a future for the good. That's all. Thank you. Any questions? Okay. Let me check any question in the chat.
I have one question. I guess at a lot of points in your talk, thank you very much for the interesting talk, first of all. At a lot of points at a lot of places you made this really interesting point that sometimes when experts are asked to write a plain language summary, they don't actually know how to estimate what the general population's understanding of a topic is, and they tend to write something that's still very difficult for them to understand. I'm wondering if you had thoughts on if it's possible to build some kind of writing support tools to specifically help experts further dilute the information or the plain language summaries that they've written.
Yeah, actually, that's a ongoing project I'm working on now. So
Wonderful.
that's very preliminary results, so I didn't put here. Actually, we found that we try to see what's the difference between sentence to sentence in the plain language version compared to the scientific version. And then we found that overall for the plain language version, the coherence score is high in the plain language version rather than in the scientific version. And then currently I try to see whether we can use between sentence coherence score as a metric to guide whether we want to add additional information or not, or whether we want to explain further or not. So this is kind of, because currently, like for the retrieval augmented large language models, they just use like log probability to guide the generation. But for this plain language summarization task specifically, I try to find if we can find other metrics to guide the generation or to guide the retrieval. So I think after I fully understand so first of all, currently I also try to manipulate GPT to see whether it can respond to my prompt. Because like for the testbed thing, we manipulate the text by replacing the sentences or something. So currently I also try to manipulate using prompts to see whether GPT can respond, for example, maintain the coherence and then improve the simplicity, whether the generated text respond to my prompt. So I think this also one possibility to build a writing aid, because first we need to understand whether those large language models respond to our prompt or not. Yeah.
Makes sense.
Thank you.
I had a question as well too. So thank you for the wonderful talk. I really like these three directions that you have on the slide for expanding the accessibility of health information, fostering interdisciplinary innovations, and enhancing clinical decision making. I was kind of curious how you see, how you see sharing insights across those three directions. So, for example, in kind of fostering interdisciplinary innovation, you can imagine that plain language summary models can kind of assist in someone reading out of discipline, even if they aren't a lay reader. I'm curious if you have other thoughts about, I guess, synergies between these three directions, and if you could develop, a model or a technique that might work for two or three of these directions all at the same time. And you see these as kind of focus directions that you want to pursue, and starting with kind of insights in each of these directions separately.
Yeah, that's a really good question. Actually, I think the overall picture, or for example, my future plan in the next 10 years will be facilitating the health communications. So I think if I want to build a system for the plain language version, I want that to be a personalized plain language generation tool. For example, for the interdisciplinary innovations, it can serve to the researchers with different background knowledge, but it's also like personalized tool then to generate the plain language version based on their background knowledge from different domains. But for this clinical decision making aspect, I think this can be applied first. It can support clinicians, because as far as my communication with clinicians, they also have trouble to explain the information correctly and accurately to the general population, to the patients. So this is also one of their concerns. So I think the personalized plain language generation tool can first facilitate clinicians to better communicate to the patients, and also to better facilitate patients to understand their, for example, clinical notes, visit summaries, and any informations they need to understand doctors' instruction, etc. And for the last one, like for facilitate the patients one, actually I collaborate with someone from the UIUC we try to collect data to see, for example, like I'm very curious about before. So when a patient go to the doctor's visit, before this visit, what information will this patient need? What information will they search on the search engine, etc., and then what information they will need after the visit. So this is after their conversation with the doctors, but they still have confusing, like they still have their own concerns that they didn't fully understand by the conversation, answered by the conversation, or what's the information is between and after. And then by analyzing that, we kind of can have an idea how we can better design this system, like what information, how to involve patients in this plain language summary, plain language generation tool, and what information we want, what content we want to feed them.
So I have a follow-up question. So I guess in your personalization work, you were mostly focused on identifying current familiarity for expert readers. It sounded like, based on what you're just saying now, generating plain language for patient maybe is a lot more than just term familiarity. I wonder if you have any insights about like what that research might look like.
Yeah, definitely. I think the first of all, the difference between the patients and the researchers, because for researchers, we can easily get what they read and what they write from S2 API. So that's a good way we can have an idea about their knowledge. But for patients, we don't have that kind of information. So that's why I think interviews or interviews to learn their real information needs, or another way I'm thinking about is to observe how they interact with GPT-4 or other search engine to see, for example, how we can, to see their conversations. Like, for example, we ask the patients to use the GPT-4 before and after the doctor visits. We see first what information they search, and then how we can best involve them in the conversation. Because, for example, if they search a term and then they got the answer, but they don't know the answer, they probably just quit the conversation. They just don't want to know it further. So how we can best engage them in the conversation seeking behavior. And lastly, how we can best present and deliver those information to the patients. I think for patients, we need more human interviews or more human work to make that done compared to the researchers' personalization project.
Thanks. That sounds very interesting.
Thank you. Any other questions?
I think we're all good here, Yue.
Thank you.
Yes, I want to thank you for your time today and thank you for an amazing presentation.
Thank you. And
Bye, everyone.
Okay. Bye.
Bye.
Thanks.
Thank you.
Hey, thank you.